Changing health behaviors is difficult. We often meet many obstacles along the way. Those could be the high cost of making those changes, whether that be financial or time or energy that needs to be invested. Sometimes the health goals seem insurmountable. They're long-term goals that seems like they will never be achieved. Also, immediate rewards, such as a delicious piece of cake, can prevent us from getting to our long-term health goal of perhaps losing weight. And at times, we just don't want to change. We know that a change might be helpful to us, but we don't move in that direction for whatever reason, whether it's because of the effort that it takes or we just aren't ready to make that next step. Moving from intent to action is part of what we need to think about when we're making health behavior changes. One clinical method of bridging the gap between intent and action is motivational interviewing. Motivational interviewing was started by Miller and Rolnick to work with problem drinkers and had some success. And since then, it's been empirically validated and supported in many different populations, adults and teens, and in many different areas, including smoking cessation, obesity, and sexual health. And actually, motivational interviewing has been shown to improve treatment outcome by up to 55% when compared to treatment as usual. It's also best used for those who are having struggles with behavioral change. So it's not meant for the ones who already know what to do and are putting some of those steps into action, but people who are struggling more with how to proceed with change. Counseling strategies used in motivational interviewing are simplistic, easy to use, good communication skills that many health providers already have. OARS is an acronym that's often used to remember the skills for motivational interviewing. The O of OARS being open-ended questions. Open-ended questions are questions that can't be answered with a yes or no, and they pull more detailed information from the individual. The idea is to be finding strengths and weaknesses within the individual that can contribute to making changes or identifying barriers that are getting in the way of changes. The next letter, A, stands for affirmations. And affirmations are sincere praises that fit with the behavior changes we as professionals know are going to work toward reaching those long-term behavioral outcomes. R, as in OARS, is reflections. And reflections are just repeating what the individual says to us. By repeating what the individual says, the individual gets to hear what they've said and see how it matches with their beliefs and with their actions. And S, finally, is a summary. And summaries are often used to wrap up the session and identify key points that, again, the professional has some expertise in knowing are going to be good matches for the individual to move forward with actions to reach their health behavior change. Well, the OARS strategies seem like simple communication tools. Putting them together in a way that's effective for motivational interviewing to help individuals move from intent to action is actually a lot more complicated. Goals for successful application include creating effective working relationship with the individual, gently guiding toward goals using your clinical expertise and not directing the patient toward what you think is best, providing respect for the individual's role in making their own decisions regarding what health behaviors they want to change, and understanding that the desire and potential for change doesn't stay the same over time. Throughout the process, motivation is increased for the individual, and a discrepancy can be developed between the individual's current behavior and their long-term health goals. Since increased independence and autonomy is a developmental goal for adolescents, motivational interviewing often fits well with this population. The non-judgmental approach is often particularly attractive for adolescents and different from their normal experiences at home and at school. Feelings of resistance are normalized. It's okay not to be ready for change, and that can reduce frustration between the health provider and the teen. Rolling with the resistance on the part of the healthcare provider rather than confronting the teen, encourages that autonomy and reduces that automatic resistance to authority. Also, the motivational interviewing approach establishes a partnership with a provider, and it elicits adolescent-determined reasons for change rather than provider-determined reasons for change. As adolescents progress toward their goal, this encourages self-efficacy, or the belief that one's ability contributes to their progress toward their long-term goal. In addition, the healthcare provider can help the adolescent organize their thoughts about health-related behaviors, risk factors, and long-term healthy lifestyle choices that could significantly impact their future health. Oftentimes, when working toward long-term health goals, there comes a point where the healthcare provider and the teen disagree on next steps. The healthcare provider often wants to push for the most optimal choice to reach the maximal health benefit. Well, the teen might not be ready for this. If the healthcare provider can take a step back and use motivational interviewing skills, they're more likely to maintain the relationship, reduce the potential for the teen to drop out of treatment, and increase the opportunity for long-term health changes.